So I'll be talking about thrombocytopenia in ICU. So I think this question was asked in one of the DNP question papers, I think in year 2008 or 2010, whatever. So the topics that I will be covering is platelet basics, the epidemiology, the time course of thrombocytopenia, prognostic significance, causes and differential diagnosis. So which would predominantly fall into sepsis, drugs, and HIV, investigations, treatment, and take-home message. So I think when you look at the function of platelets, predominantly it has two functions. So one is the hemostasis, which is to stop bleeding, and as a prothrombotic state. So it can create thrombosis in major blood vessels, including veins and arteries. So when you look at the platelet, not only does it have hemostasis and prothrombotic, it also produces certain factors called procoagulant factors and pro-inflammatory factors. And some of the procoagulant factors that are produced are platelet activating factors and complement proteins. And some of the pro-inflammatory factors that are produced are cytokines and oxidants. So, what is the consequence of platelet activation? So, the platelet, when it gets activated, it can have beneficial effects and harmful effects. So, some of the beneficial effects is it can cause wound healing, I think, which is very useful. So, the platelet activation is needed for facilitating wound healing. And another important function is to maintain the endothelial uh, integrity in the vessels, blood vessels. So basically, platelets are needed to maintain the endothelial integrity to prevent vascular leakages, and it reduces the vascular permeability. So this is extremely useful in conditions like dengue or any other multi-organ dysfunction due to viral sepsis, because the predominant pathophysiological mechanism is vascular, extensive vascular leakage. So I think platelets are needed because typically in any disease condition where you see fall in platelet count, I think the pathognomonic finding would be the loss of vascular integrity due to the endothelial spaces which get disrupted. So I think platelet function is needed to maintain the integrity, and it is also useful for inflammatory and host defense. I think it has a pro-inflammatory and anti-inflammatory effect, so which is useful for host defense mechanism. So the harmful effects, I think thrombocytopenia can lead to impairment of the capillary network. Because what typically happens is when platelets get activated, there will be prothrombotic state. So there will be platelet clumps that gets formed in the microcirculation. So that can lead to tissue hypoxia and organ dysfunction. And there can be cascading of this anti-inflammatory or pro-inflammatory effect and worsening of coagulopathy due to platelet activation. So these are some of the broad headings under which beneficial effects and harmful effects of thrombocytopenia or platelet activation happen. So why is platelet pathology harmful? Because the platelet has a direct effect on organ dysfunction. So when there is a platelet abnormality, it can lead to organ dysfunction, and it can lead to bleeding. As we already mentioned, thrombocytopenia can lead to bleeding, and even thrombocytopenia can be associated with a prothrombotic phase like ITP or TTP, mainly TTP and HUS, where it is a prothrombotic state in the presence of thrombocytopenia. And influence on patient management. So what essentially it means is when platelets are low, so it can interfere with your therapeutic procedures like inserting CVC or dialysis catheter or any other procedures that are typically done in ICU. And low platelets does mandate investigative modalities. So one needs to investigate low platelet count. So it involves investigational approach for any patient who has a low platelet. And there are certain drugs that cannot be given, so it has influence on management. Because when there is thrombocytopenia, there are certain drugs like typically what we routinely use, DVT prophylaxis with the low molecular weight heparin. So these are the drugs that cannot be used. So it has bearing on the type of drugs that you cannot use. I think that needs to be borne in mind. And most importantly, I think low platelet is also an important marker of severity of illness, because although low platelet is something you may ignore, even though when there is no bleeding manifestation, but what it really indicates is it can be a marker of severity of illness, and it helps you to prognosticate the disease and the underlying disease in a patient. So, how do you define thrombocytopenia in ICU? So, thrombocytopenia is where the platelet counts is less than 150,000 per microliter, and it is one of the most common abnormality seen in ICU. Up to 50% of our ICU patients can have this thrombocytopenia. So it is quite common. And as I mentioned already, thrombocytopenia has a direct bearing on the mortality and poor ICU outcome. And thrombocytopenia as a marker of illness severity and predictor, do we have any studies? So there are quite a few studies. So it has been shown that thrombocytopenia is associated with higher Apache and higher SAPS and higher multi-organ dysfunction score. And what essentially that means is higher Apache, higher SAPS is associated with higher MUD. So there is a good correlation between thrombocytopenia and higher severity scores. So if you look at the studies, I think there are two studies, one from Germany and from Australia. As you see, the ICU mortality with the low platelet was 39% as opposed to 24% in patients with normal platelets, and that was statistically significant. And when you look at hospital mortality also, I think where patients with low platelets had higher hospital mortality as compared to normal platelets, and that was statistically significant. And if you look at duration of mechanical ventilations, patients who had low platelets had a longer duration of mechanical ventilation, 11 days versus 5 days, and that was also statistically. So what essentially this study shows is, if you have a patient with low platelets, we cannot ignore, because it has a bearing on ICU mortality, hospital mortality, and duration of mechanical ventilation. And another thing that was found in these studies was patients with low platelets invariably necessitated the need for more blood product transfusions. So it may have been PRBCs or platelets or FFPs. So they had more blood product administration when they had low platelet count. So when you look at this study, so this was from a Canadian group, so which looked at thrombocytopenia in patients receiving thromboprophylaxis. So if you see, 15.3% had mild thrombocytopenia, and around 5.1% had moderate thrombocytopenia, and 1.6% of the patients who were receiving thromboprophylaxis had severe thrombocytopenia. So in our ICU patients, pretty much most patients do get thromboprophylaxis. So we need to have that in mind, that that has a bearing on causing your platelets to drop. So that is the occurrence rate in patients. So it's around 2 to 15% is what you can keep in mind as the risk for developing low platelets, which is attributable to thromboprophylaxis. And especially if you have moderate, mild, I think it is found to have no significant bearing. But if you have moderate and severe thrombocytopenia, I think it did have a bearing on increase in the ICU and hospital mortality. So when you look at this particular study, which came from the French group, so if you look at the survival, so the survival rates, is if the platelet count is 10 to 30% drop, that is mild thrombocytopenia, I think even that had little bearing on reduced survival. But I think the significant drop in the survival, this is the Kaplan-Meier curve. So this is the survival, and this is the time after ICU admission. So if there is 30 to 60% drop, which is moderate thrombocytopenia, I think your survival rate was much lower. If it is more than 60%, I think your survivals comes down. So the severity of thrombocytopenia had a linear correlation to the survival. So the greater is the fall in platelets, I think the fall in survival also was greater. And what they found is the fall in platelets typically happens at day 4. So initially it may not manifest, but I think over the course of days, the thrombocytopenia gets manifested. So when they put things together, I think when there is 30% drop in platelets, it was found to be an independent predictor of death, which was the odds ratio of 1.54, and that was statistically significant. So the greater the fall in platelets, I think greater is the risk of death. And the fall in platelets, at least from this study, typically happens from day 4. So let's look at the time course of platelet counts in critically ill. So as you see, if you look at this table, this was from a Belgian study. So the fall in the platelets reached the nadir. Nadir means the bottommost platelets occurred at day 4. And this happened in both survivors and non-survivors. So typically at day 4, it reached the rock bottom, and return to baseline in both this group happened after 1 week. So this was the Belgian study. But when you look at the survival, see, when you look at day 4 thrombocytopenia, so it was around 54%, and at day 14, I think platelet recovery tends to happen, and it was 20% at day 14, so the thrombocytopenia. But when you look at the mortality at day 4, in patients who had thrombocytopenia versus patients who did not have, I think patients who had thrombocytopenia, the mortality was higher, 33% versus 16%. That was statistically significant. And even at day 14, if patients continue to have thrombocytopenia, the mortality was 66% versus 16%. So basically, this study also sort of endorses the viewpoint that thrombocytopenia is bad, and thrombocytopenia typically occurs after day 4. So, and it is an important marker and an independent marker of mortality. So, what are the mechanisms of thrombocytopenia in ICU? So, the key mechanisms is ongoing bleeding. So, any patient who has an ongoing bleeding or hemodilution due to excessive or massive fluid resuscitation can lead to thrombocytopenia. So, the second important class of thrombocytopenia is reduced production of platelets, and this reduced production of platelets typically happens in any bacterial infections or drugs that we use in ICU or inflammatory mediators and the liver disease. So, liver disease are one of the common admissions in ICU. They do have low platelets or bone marrow disorders. So, these are the disorders where there is a reduced production of platelets. And the third category is the increased sequestration of platelets that typically happens in ARDS patient or in any splenectomy, hypersplenism or portal hypertension patients where there is increased sequestration of platelets. And the fourth category is where there is increased destruction of platelets due to autoimmune mechanisms, due to like immune thrombocytopenic purpura or any other autoimmune conditions which may lead to immune activation that leads to platelet destruction, or all the extracorporeal therapies that we use in ICU like hemodialysis or ECMO or plasmapheresis. Any of these lead to any extracorporeal circulation leads to destruction of platelets. And pseudothrombocytopenia occurs in coronary syndrome patients where they use this drug eptifibatide. So it is known to cause pseudothrombocytopenia. So what are the differential diagnosis of thrombocytopenia in ICU? So as I mentioned, in ICU, it is always common conditions that should come to your mind. So sepsis is the common condition which tends to be the cause for thrombocytopenia in many patients, and sepsis can be viral sepsis or bacterial sepsis, and any chronic viral infections like HIV, HCV can also cause low platelets. And drugs, I think we will have a separate slide on the drugs that causes thrombocytopenia. And as I already mentioned, liver disease or DIC, disseminated intravascular coagulation. And there can be typical hematological conditions that get admitted to ICU like ITP or TTP or hemolytic uremic syndrome, thrombotic purpura, and immune thrombocytopenic purpura. So these are the typical conditions which can get admitted to ICU with bleeding manifestations. And this is macrophage activation syndrome. So these are the typical hematological causes of thrombocytopenia and bone marrow disorders. So the immunological conditions can be any of the autoimmune conditions, which like SLE, Ivan syndrome, or rheumatoid arthritis. So any of the immunological condition can lead to thrombocytopenia in ICU, and even the massive transfusion can lead to thrombocytopenia. Massive transfusion leading to transfusion reactions can lead to thrombocytopenia in ICU. And the last category would be idiopathic or unknown. So pictorially, I think if you can remember, these are the differentials that typically happen in ICU. So what about drug-induced thrombocytopenia? I think there are around 15 drugs. So antibiotics remain the commonest cause of thrombocytopenia. So beta-lactamase inhibitors, cephalosporins, carbapenems, and quinolones. I think all of these can cause thrombocytopenia. And anti-epileptics is another group like carbamazepine, valproate, phenytoin, or phenobarbital. So these can also cause. So I would urge you to remember it by the classes. So antibiotics is one class, anti-epileptics is one class which can lead to thrombocytopenia. Alcohol is one category, and heparin is a common culprit. So don't undermine the use of your low molecular weight heparins, which can also cause uh, thrombocytopenia. And anti-snake venom serum, when you're using it for a snake bite, that also can cause thrombocytopenia. And the common cardiac drugs that you would use, aspirin and NSAIDs, they can also cause thrombocytopenia. And the other drugs would be acetaminophen and chemotherapy drugs, and H2 blockers also can cause. So if you remember some of this picture, I think it would be easy for you to recall the causes of thrombocytopenia. So we'll just talk about heparin-induced thrombocytopenia because this is something which can happen quite not uncommonly, and we need to have high index of suspicion to suspect heparin-induced thrombocytopenia. So basically what happens in heparin-induced thrombocytopenia, so these platelets express this antigen called PF4 heparin complex. So there is an increased antibody production to this PF4 heparin complex that gets manifested on the platelet count, and that leads to the autoimmune mechanism and thrombocytopenia. So, what is the seroprevalence of this PF4 heparin complex expression? So, it is around 10.8% at admission. So, anyone who receives heparin, I think 10.8% of the patients are known to manifest with this PF4 heparin complex expression, and this expression can increase up to 29.4% at day 10, but not necessarily anyone who expresses this develop thrombocytopenia. That is something you need to bear in mind, that not all patients who express this PF4 heparin, because as you see, significant percentage of patients do express this PF4 heparin complex, but not everyone develops thrombocytopenia, or not everyone develops prothrombotic state. So that is something you need to keep in mind. So the clinical features, so the diagnosis of it is predominantly the clinical suspicion, or having high index of suspicion. So when do you suspect patients with HIT? So when someone has a platelet drop of more than 50%, or where they reach nadir is the bottom point of around 50 to 80,000, or when the duration of the thrombocytopenia happens somewhere at around 5 to 14 days. I think this is when you suspect. So more than 50% drop, or when platelet count comes down to around 50 to 80,000, or when you see platelets dropping in this time frame of 5 to 14 days. If it is happening less than 24 hours, then you have to suspect previous exposure to heparin. So I think why is this important? Because although platelets are low in heparin-induced thrombocytopenia, but there is a significantly increased risk of having both arterial and venous. So the treatment is you would not give platelets, because giving platelets will worsen the risk of developing arterial or venous thrombosis. And as you see, the odds ratio is up to 12. So the risk of developing arterial and venous thrombosis is 12. So there is this, Canadians have come out with this diagnostic criteria for heparin-induced thrombocytopenia. As I said, it's purely clinical. So thrombocytopenia, timing of onset of platelet, as I said, it's 5 to 14 days is the time when a platelet drop starts manifesting, or someone having thrombosis gets points, and other causes of platelet fall. So this is the sort of a diagnostic criteria you can apply and diagnose HIT. So when should we investigate patients with thrombocytopenia? So anyone who has platelets less than 100,000, you would suspect, or more than 30% drop in platelets, you should think of investigating this group, or rapid drop in platelets in 24 to 48 hours. I think so. These are the conditions which mandate investigations of the thrombocytopenia, or where platelet drops but there is no recovery in 5 to 7 days. So this is another group where you would consider evaluating, or where patient shows initial improvement in the platelet count, it plateaus and then has a drop in the platelet count. I think this is also a situation where it mandates that you need to investigate the cause of low platelet count, or other appropriate clinical situation. So this is the scenario. I mean, we would see this scenario quite commonly in ICU, and this is where it is required that we investigate the cause of low platelets. So I think this slide would be extremely important for all the trainees. How do you approach patients with low platelet in ICU? I think if you remember this slide, I think this would be extremely useful for your practical applications. So whenever you have a patient with low platelet, I think first thing we need to do is peripheral smear. So once you do a peripheral smear, I think if you have increased clumping of platelets, then you would and if the platelet morphology is normal but there is increased clumping, then you would call it as artifactual. So maybe due to the sampling, so you may have to repeat the platelet count. So if there is a true drop in platelets, so if there is a true thrombocytopenia in peripheral smear, and if you see a giant platelets, then you would call it as hereditary thrombocytopenia. So if there is a true thrombocytopenia and a giant platelets, you call it as hereditary thrombocytopenia. If there is true drop in thrombocytopenia and you see these cells in the peripheral smear, which is schistocytes, then you would consider hemolytic uremic syndrome, or thrombotic thrombocytopenic purpura, or DIC. So the investigations then would be all this: LDH, bilirubin, haptoglobulin, and you would do PT, APTT, D-dimers and fibrinogen. So if you see this is dangerous, this is a bad news. So if you see blast cells, then you know it is, or blast cells or nucleated RBCs, then you know it is probably some sort of a leukemia or blood dyscrasia. So then you would think of bone marrow disorders, and the investigation of choice would be bone marrow aspirate. So if you see these micro spherocytes, if you see a small spherocytes, I think the diagnosis is Yuan syndrome, and then the test that you would do is the DAT, reticulocytes, LDH, and bilirubin. So if you see this, I think these are the things which we would see commonly in ICU. If you see a lot of lymphocytosis, and if you see abnormal cells, dendritic cells, or polymorphonuclear leukocytosis, I think that's when you think it's morely sepsis due to bacteria or viral. Then your investigations would be ESR, CRP, chest X-ray, virology, blood culture. So you would test for sepsis or any other infective cause. If it is isolated thrombocytopenia without any of these, then you would go ahead for looking out for ITP or chronic viral conditions like HIV, HCV. HIT is also something, because as I kept reiterating, HIT is a mainly clinical. So you look at the fall of platelets and the duration of drop in platelets, and then you would look for HIT antibodies. So I think these are the other conditions that you would think when all these conditions are not there. So this investigation flowchart, if you remember, I think our approach to investigational directions to thrombocytopenia would be a lot more clearer, or we'll have a lot more clarity on that. So when you look at the other pathophysiological mechanisms why thrombocytopenia occurs, so this is the recent update where they have shown there is a when there is a damage to the cell, so there is a histone production from the cell. So these histones, either they appear as a free form or they can be attached to DNA, and these histones lead to the clumping of the platelet aggregation. So this is one of the mechanisms that is cited. And when you say there is an immunologically mediated thrombocytopenia, then these histones get attached to something called extracellular traps, and that leads to endothelial damage, which leads to cellular leakages and vascular leakage. So these are some of the newer proposed mechanism for platelet thrombocytopenia. So we finished about the causes, differential diagnosis, and we looked into the diagnostic approach. We spoke briefly about drugs causing, we spoke briefly about hits. So let's look at the treatment. So the treatment of thrombocytopenia, almost always, as you saw, there is always an underlying cause. So giving platelets is not the solution. So we need to identify what is underlying cause and treat the underlying cause. And supportive care, I think, would include platelet transfusion. So we'll talk briefly as to when we would consider platelet transfusion. And supportive care would also mean anticoagulation, and this typically is useful when you are dealing in patients with hemolytic uremic syndrome or thrombotic thrombocytopenic purpura or HITS, so where anticoagulation may be needed. And most importantly, you will be focusing more on etiology specific, because you need to ascertain what is underlying etiology and then plan treatment accordingly. And your treatment in all these three will be guided by whether patient is in a pro bleeding stage or pro hemorrhagic state, or your patient is in a pro thrombotic stage, or is your low platelets warranting or mandating any additional tests to identify the underlying diagnosis. So whenever you have thrombocytopenia and you're contemplating giving platelets, I think you need to have these three things popping up in your mind, whether you're dealing with pro-hemorrhagic phase, which means you may have to give platelet, or pro-thrombotic, or any other additional tests that may be needed to establish the underlying diagnosis. So if your answer is yes, there is a risk of bleeding and low thrombocytopenia, risk of bleeding or thrombocytopenia, or there's an active bleeding with thrombocytopenia, then the answer would be, would you be wanting to give prophylactic platelets or platelets? So we will look into some of the studies. So when you look at this particular study, which came in NEJM in 2013 by the UK group, so they looked at prophylactic platelets versus no prophylaxis in 600 patients, and 301. So these were patients with thrombocytopenia. So where the 301 patients did not get prophylaxis, 299 got prophylaxis. As you see, the bleeding was not significantly different, because statistically it was not significant. So which means either you give prophylaxis or no prophylaxis, and prophylaxis was given in this study when platelet count was less than 10,000. But even then they did not find significant difference in the bleeding between prophylaxis and no prophylaxis, and duration of bleed was more in patients who did not get prophylaxis. But after this study, this was another study which again came. So as you see, with prophylaxis, the bleeding risk was little higher, and as you see, the statistically P was significant in this particular study. So what is the consensus recommendation for treatment with platelet transfusion? So the decision to transfuse again should be based on platelet count. So I think less than 10,000. So there is some evidence that giving prophylaxis will prevent further bleeding or more life-threatening bleeding. So you may have to consider. So decision to transfuse, when there is active bleeding, obviously we may have to give platelet count. And active bleeding, again, it depends on the site and severity of bleeding. And etiology is important to determine whether we need to give platelets. And this is a question that we need to ask, whether there is a bleeding risk or a prothrombotic. Because if you are dealing in patients who is at a risk for prothrombotic state, then obviously you should not be giving platelets, rather you should be considering anticoagulation. And when patient has risk of bleeding, I think that risk has to be seen whether it is a problem with platelet function, because there are a lot of clinical conditions where platelet function is affected, or patients who are on antiplatelet drugs where platelet function gets affected. So even that you need to ascertain. And bleeding has to be looked into the context of any surgical procedure or any interventional procedure that you may be planning. So that is when you may have to consider whether platelets are needed to perform that procedure. So these are the clinical situations that you need to ascertain before you think of giving platelet count, or any other associated treatments that you are planning to give which may have a bearing on the platelet count. So if you look at the level of recommendation for platelet transfusion, so I think if platelet count is less than 10,000, so the recommendation for giving platelets is moderate, although the quality of evidence, as you saw, the two NEGM trials which were little contradictory, is little low. But I think we would agree if it is 10 or less than 10, we may have to consider giving. So before CVC, the recommendation is 20,000 as the platelet count, and before lumbar puncture, 50,000. I think for all practical reasons in intensive care, we consider 50 as a ballpark, and we want platelet count to be little more than 50 before doing any major. But for CVC, it says 20,000. And before major elective surgery, I think all of us are clear, it is 50,000. And prophylactic prophylactic transfusion for non-thrombocytopenic patients before bypass, they say there's no need for any transfusion. And intracranial hemorrhage due to platelet transfusion is not found to be helpful. So this is the recommendations that have come out in hematology journals. So the take-home message. So when you look at platelets, I think platelets has multimodal effects. So it has effect on coagulation. It does produce pro-inflammatory and anti-inflammatory factors, and it does have a bearing on immune function. And thrombocytopenia, all of us have to understand, is common in ICU. It is up to 50% of the patient can have thrombocytopenia. Most common causes in ICU would be sepsis, the drugs, all the drugs that I listed. So antibiotics, anti-epileptic drugs, and NSAIDs, aspirin. So I think all alcohol is another common cause. So this, if you remember those categories, I think that would be reasonably good enough. Dilutional, where you give massive transfusion or massive resuscitation. So they have a bearing on causing low platelets or transfusion reaction and liver disease. I think these tend to be common causes in ICU. And diagnosis of it, as I mentioned, it is purely clinical. You look at the drop of platelets more than 50% or reaching the nadir of 50 to 80K in about 5 to 14 days. I think that is when the platelet drop. And when patient is on heparin, you would suspect possibility of hits, and then you would look for hit antibodies. So investigations, as I showed that algorithm, I think it is extremely important that you remember that. So investigation starts with peripheral smear. So we need to investigate low platelet when your platelet count is less than 100,000 or more than 30% drop, or when there is a rapid drop of in 24 to 48 hours, or where there is no recovery in 5 to 7 days, or where platelet count has improved and then again drops. I think these are the clinical situations where it would mandate investigations. And with regards to treatment, as I already mentioned, it is very much dependent on the platelet count. And by platelet count, again, you need to look and whether it is in a pro-hemorrhagic phase or whether it is in a pro-thrombotic phase. I think these are the two elements that you look to determine whether you give platelet or do not give platelet. And etiology is very important before you ascertain whether platelet transfusion could be given. As I said, if there is an active bleeding or you believe there is a pro-hemorrhagic phase, the risk of bleeding is high, and the thresholds that we already mentioned, if you're planning a surgery more than 50,000, CVC 20,000 or 10,000, you could consider giving. If it is a pro-thrombotic phase, obviously you would refrain from giving this platelet, and maybe you have to try to see and what the cause of the thrombocytopenia is, and you may have to consider anticoagulation in patients like thrombotic TTP, thrombotic thrombocytopenic purpura, or HITS for that matter. So thank you very much. So I would end my talk with this saying. So I think any thrombocytopenia, you need to have commitment, because as it says, for a committed person, there's no such thing as a failure, just lessons to be learned on the way. So we have good clarity and we are committed to investigate. I think we'll always find the cause for low platelet count. Thank you very much.